Manual therapy techniques for increasing mobility. Following injury, soft tissue loses some of its ability to tolerate the demands of functional loading. Specific soft tissue mobilization involves specific, graded, and progressive applications of force using physiologic, accessory, or combined techniques to promote collagen synthesis, orientation, and bonding in the early stages of the healing process. Soft tissue mobilization should be used in conjunction with rehabilitation protocols to restore the kinetic control of the tissues. A variety of manual therapy techniques can be used in injury rehabilitation to improve mobility and range of motion. One technique to aid in the mobility and the range of motion improvement in athletes is myofascial release stretching. Myofascial release is a term that refers to a group of techniques used for the purpose of relieving soft tissues from the abnormal grip of tight fascia. This is a form of stretching. Fascia is a type of connective tissue that surrounds muscles, tendons, nerves, bones, and organs. It is continuous from head to toe and it is interconnected in various sheaths or planes and must stretch and move freely during motion. If there is damage to the fascia as a result of injury, disease, or inflammation, it can not only affect the adjacent structures, but may also affect areas far removed from the site of injury. Fascia tends to soften or release in response to gentle pressure over a relatively long period of time. Myofascial restrictions are unpredictable and may occur in different planes or directions of movement. Myofascial treatment is based upon localizing the restriction and moving into the direction of the restriction. Sometimes myofascial release and joint mobilization have been lumped together. Although they are very similar, they are different as well. Joint mobilization is used to restore normal joint arthrokinematics, and there are specific rules regarding the direction of the movement and the joint position based upon the shape of the articulating surfaces. Myofascial manipulation focuses on large treatment areas, whereas joint mobilization focuses on specific joints. Releasing myofascial restrictions over a large treatment area can have a significant impact on an individual's joint mobility. The progression of the technique is to work from superficial fascial restrictions to deeper restrictions. Once the superficial restrictions are released, then deeper restrictions can be located and addressed without causing any additional damage to superficial tissues. Joint mobilization should follow successful myofascial release and will likely be more effective once soft tissue restrictions are addressed and eliminated. As extensibility is improved in the myofascia, elongation and stretching of the musculotendinous unit should be incorporated. Strengthening exercises are recommended to enhance neuromuscular re-education, which helps to promote new and more efficient movement patterns. As freedom of movement improves, postural re-education may help to ensure the maintenance of less restricted movement patterns. Acute cases generally resolve in a few treatments. The longer the condition has been present, the longer it will take to resolve. It is recommended that treatments be done at least 3 times per week for myofascial release. Myofascial release can be done manually by an athletic trainer or by the patient stretching using a foam roller or even other objects such as a ball. Strain counterstrain is an approach to decreasing muscle tension and guarding that may be used to normalize muscle function. It is a passive technique that places the body in a position of greatest comfort, thereby relieving the patient's pain. Sources of dysfunction may include sitting in a poor posture for prolonged periods of time, acute injury, or even leg length differences. Strain counter strain, or SCS, is the fourth most commonly used osteopathic manipulative technique, following soft tissue techniques, high velocity, low amplitude thrust, and muscle energy techniques. This is also known as positional release. Strain counter strain is a passive positional technique aimed at relieving musculoskeletal pain and dysfunction through indirect manual manipulation. Strain counter strain treatment begins by identifying diagnostic tender points related to musculoskeletal dysfunction. Once a tender point is identified, the practitioner manually monitors the tender point while positioning the patient in a position that relieves the palpated tenderness. This position of comfort is typically obtained by shortening tissues around the tender point. The practitioner need not maintain palpation pressure while supporting the patient passively in the position of comfort, but may maintain gentle touch to the tender point to assure accurate palpation afterward. Release of the tender point occurs approximately 90 seconds, after which the practitioner slowly returns the patient to a normal resting position. Tender points are located in deeper muscle, tendon, ligament, or fascia. Acupuncture pressure points are located in or just beneath the skin, as opposed to the tender points that are much deeper. These tender points are characterized by tense, tender, edematous spots on the body. Edematous spots are swollen with an extensive accumulation of fluid in the tissue. They are typically 1 centimeter or less in diameter, with the most acute points often being 3 millimeters in diameter or smaller, although they may run a significant length of the muscle. There can be multiple points for one specific dysfunction. Points are often arranged in a chain, and they are often found in a painless area opposite of the site of pain and/or weakness. For example, neck pain and/or tension headaches. A tender point may be found on either the front or the back of the patient's neck and shoulders. The athletic trainer will have the patient lie on the patient's back and will gently and slowly bend the patient's neck until the tender point is no longer tender. After holding that position for approximately 90 seconds, the athletic trainer should gently and slowly return the neck to its resting position. When the tender point is pressed again, the patient should notice a significant decrease in the pain at the former tender point spot. The stretch reflex explains the physiological rationale for the strain counter strain technique. When a muscle is placed in a stretched position, impulses from the muscle spindles create a reflex contraction of the muscle in response to stretch. With strain counter strain, the joint or muscle is placed not in a position of stretch, but instead a slack position. The muscle spindle input is reduced and the muscle is relaxed, allowing for a decrease in tension and pain. This is a passive technique. You are going to tell the patient to relax. The patient should not be doing anything to help with the treatment. It is an indirect technique. You are not going into the barrier, you're going away from the barrier or restriction. Tender points, these are areas of tenderness in the body that have varying levels. We are going to find a tender point, but we need to make sure that there is no radiation. If we poke this tender point, there is going to be pain or tenderness at that area that we are palpating. However, there will not be any radiating pain out or away from that area. This is one distinction between a tender point and a trigger point. A trigger point will often be associated with radiating pain. Technique is important. First, we are going to find the tender point. Palpate and place your finger upon the tender point. Be careful, as this may be uncomfortable for the patient depending upon the level of pain the tender point induces for the patient. Next, we're going to place our patient in a position of ease, and we're going to remind our patient to relax. Usually, this position of ease is with the muscle in a shortened state. For example, if we have a biceps brachii tender point, we would flex the elbow to shorten the biceps muscle. There is some nuance with this technique. But in general, placing the muscle in a shortened position is usually the correct technique. This position of ease should diminish the pain. The target goal is 70 to 100% reduction in the level of pain for the patient. If we do not have this level of reduction of pain, then we need to reassess the position of ease. If the pain is reduced less than 70% for the individual, then the tender point will likely still be there when the treatment is finished. So this is important. We can increase this position or move the position around until we achieve at least 70% reduction in pain. Next, 90 is the magic number. We will hold this passive position of ease for at least 90 seconds. After 90 seconds, return the patient to the position of neutral. It is key that your patient does not help you. This movement should be 100% passive. This passive movement allows for a reset of the tender point. It is theorized that myofascial tender points created by body dysfunction causes an incorrect neural output from the muscle spindles, which results in pain at the tender point site. By placing the segment in a position of ease, the affected muscle spindles finally can relax. When we slowly return them to a normal position from the position of comfort, this prevents the muscle spindle reflex from occurring, so the pain is relieved. These tender points are often related to other tender points and exist in a chain. The clinician must find these other tender areas and treat them all for pain to finally be relieved. There are maps of tender points throughout the body and positions of ease to treat them. This is an area of study in which a clinician can become a specialist. Positional release therapy is like the strain-counterstrain technique. The primary difference between the two is the use of a facilitating force or compression to enhance the effect of the positioning. Positional release therapy is an osteopathic mobilization technique where the clinician moves the body part into a position of greatest relaxation. The clinician finds the position of greatest comfort and muscle relaxation for each joint with the help of movement tests and diagnostic tender points. Once a tender point is located, the tender point is maintained with the palpating finger at the subthreshold pressure level. The patient is then passively placed in a position that reduces the tension under the palpating finger, producing a subjective reduction in the tenderness reported by the patient. This specific position is adjusted throughout the 90-second treatment to maximize the position of reduced tension. Research has suggested maintaining contact with the tender point during the treatment period exerts a therapeutic effect for the patient. This technique is one of the most effective and gentlest methods for treatment of acute and chronic musculoskeletal dysfunction. Active release technique is a new type of manual therapy to correct soft tissue and muscles, tendons, and fascia caused by fibrotic adhesions resulting from acute injury, repetitive or overuse injuries, constant pressure, or tension injuries. When a muscle, tendon, fascia, or ligament is torn or a nerve is damaged, the tissues heal with adhesions or scar tissue formation rather than the formation of brand new tissue. Scar tissue is weaker, less elastic, less pliable, and more pain sensitive than healthy tissue. Fibrotic adhesions disrupt normal muscle function and affect the biomechanics of the joint complex, leading to pain and dysfunction. Adhesions can lead to inflammation, increased adhesions, fibrosis, muscle imbalances, weak and tense tissues, decreased circulation, hypoxia, and symptoms of peripheral nerve entrapment, including numbness, tingling, burning, and aching. To perform active release technique, the clinician locates adhesions in the muscle, tendon, or fascia that are causing the problem. Once an adhesion is located, the clinician will trap the affected tissue by applying pressure or tension with the thumb or finger over these lesions in the direction of the tissue fibers. The patient is then asked to actively move the body part such that the musculature is elongated from a shortened position while the clinician continues to apply tension to the lesion. This should be repeated 3 to 5 times per session. By breaking up adhesions, the scar tissue is softened and stretched, which improves range of motion, increases strength, and improves circulation, which optimize healing. Treatments tend to be uncomfortable during the movement phase as the scar tissue or adhesions tear apart. This is temporary and should subside almost immediately after the treatment. An important part of the treatment is activity modification, stretching, and specific exercises. The Graston Technique is an instrument-assisted soft tissue mobilization utilized to break down scar tissue and fascial restrictions, as well as stretch connective tissue and muscle fibers. This technique uses 6 handheld, specifically designed stainless steel instruments shaped to fit the contours of the body to scan an area and then treat the injured tissue, causing pain and restricting motion. A clinician will palpate for painful areas, feeling for unusual nodules, restrictive barriers, or tissue tension. The instruments can help to magnify existing restrictions so that the clinician can feel through the instruments. The instruments can then be used to provide precise pressure to break up scar tissue and to restore normal function. Instruments with narrow surface area at their edge will separate fibers. Lubrication is typically applied to the skin, allowing the instruments to glide over the skin without causing irritation. Most frequently, a cross-friction massage in multiple directions is utilized. This allows the instrument to stroke or rub against the grain of the scar tissue, and the clinician creates small amounts of trauma to the affected area. This causes inflammation, which increases the rate and amount of blood flow to the area. The theory is this process will help to initiate and promote the healing process of the affected soft tissue. It is common for the patient to experience some discomfort during the procedure and possibly some bruising following the treatment. Another technique is known as Rolfing. Ida P. Rolf was an American with a PhD in biochemistry in the early first half of the 20th century, when women with doctorates in science were rare. She developed an interest in homeopathic medicine while on leave from her work. The Rolf Institute was opened in Boulder, Colorado. The Rolfing technique is based upon Dr. Rolf's realization that fascia surrounds all tissues in body structures. It influences the tissue and the surrounding structures. Dr. Rolf observed that the body centered around a vertical line of pull created by gravity. When the body is aligned and balanced in arrangement, then the body is most efficient and healthy. With the gravity's continuing pull, stresses and injuries can occur to pull the body out of its normal alignment. Imbalances occur and cause the body to become painful, malaligned, and inefficient. Rolfing includes improving the body's posture, so all systems, including breathing, flexibility, strength, and coordination, function optimally. Gravity and the body have a constant relationship. Gravity is the victor unless the body is optimally conditioned. The goal of Rolfing is to align the head, neck, shoulders, trunk, pelvis, and legs in line with gravity. Rolfing consists of some principal ideas of the human body structure and its posture. 1. Most human beings are significantly out of alignment with gravity. 2. We function better when we are aligned with gravity. And 3. The human body is so plastic that its alignment can be brought into harmony with gravity at practically any time in life. The treatment techniques include 10 sessions, each one focusing on a central theme, goals, and a sequence of structural interventions. The 10 sessions are divided into 3 categories: sleeve sessions, core sessions, and integrating sessions. The goal of the treatments are to balance and realign the body in all planes. If the pain is resolved, imbalance is no longer an issue, and the body should perform more efficiently. The first of the 10 sessions are the sleeve and include, in order of sequence, sessions on respiration, balance through the legs and feet, and sagittal balance. The second group of sessions, the core sessions, including the base of the core or midline of the legs, abdomen, psoas for pelvic balance, the sacrum, weight transfer from head to feet, and the relationship of the head to the rest of the body, primarily the occiput-atlas relationship, then to the rest of the body. The final sessions are the integration sessions, including 2 sessions on balance between the upper and lower girdles, and a final session on balance through the whole system. The goals for each session are different and progressive. The goals for session 1, release the fascial layer below the skin surface. For session 2, free up and reorganize fascial planes in the feet and legs. Session 3, reorganize the lateral alignment using this session as a transition between superficial and deep fascial layer treatments. Sessions 4, 5, and 6, release the deep fascia closest to the spine and balance the pelvis and back structures. Session 7, balance the head and neck. Sessions 8, 9, and 10, these are integrative sessions where superficial, middle, and deep fascial layers are worked with and integrated. Since gravity tends to shorten fascia, Rolfing techniques should lengthen fascia. Once an evaluation is complete and identifies shortened segments, Rolfing involves the application of firm strokes with gentle pressure to affect fascial restrictions. This procedure by practitioners is often called mildly uncomfortable for its patients. Neuromobilization is one of the most dangerous manual therapy techniques and should only be used with care and precision. Clinicians must not use this treatment lightly. Neuromobilization is discussed so you can be aware of its proper use and possible consequences. The neural system is continuous throughout the body. Nerves are surrounded with fascia and can be affected both directly and indirectly to fascia and adjacent tissues. Neural injuries can refer to distant areas of the body. Referred pain of neural injuries is different from myofascial pain referral patterns. Pain can be referred from nerve or tissue injury and follows pathways. It is described as tingling or burning. Pain can also jump from one area to another. Peripheral afferent nerve fibers carry painful signals and are called nociceptive fibers. Stimuli that activate pain fibers include mechanical forces, chemical irritants, and hot and cold temperatures. The A delta and C fibers respond to pain stimuli that respond in a pain reflex withdrawal. These nerve fibers are myelinated, afferent fibers that are excited by a mild mechanical stimulus. The A alpha afferents are high threshold mechanoreceptors that can also respond to temperature stimuli. The A delta fibers are stimulated in sudden injuries. About 75% of peripheral pain receptors are C fibers and respond to both mechanical and chemical stimuli. C fibers are also stimulated by swelling and stiffness and cause an aching sensation that occurs with vasodilation. C fibers and A delta fibers both respond to inflammation. Normal neural tissue does not refer pain at rest or during normal movement or activity. Pathological conditions produce referral patterns both proximally and distally from the site of pathology, referred to as pathoneurodynamics. The source of the pathoneurodynamics can either be intraneural or extraneural, coming from injury either to the nerve itself or to the surrounding tissue interacting with the nerve. Neuromobilization precautions. Continual feedback from the patient about the area's response to the treatment is required at all times. Avoid reproduction of painful symptoms, especially numbness and tingling sensations. It is easier to irritate upper limb nerves than lower limb nerves because the upper limb nerves are smaller and traverse more complicated paths around bones and through muscles than those of the lower limbs. Diabetes, AIDS, and other systematic diseases can weaken the nervous system. Take extra care when applying neuromobilization techniques on patients with these conditions. Circulatory system disturbances should be monitored. Where the circulatory system goes, the nerves are right beside it. If a nerve is mobilized, the circulatory structure next to it will also be mobilized. Contraindications to neuromobilization include malignancies of the nervous system or vertebral column, acute inflammatory infections, areas of instability, and spinal cord injuries, suspected disc lesions, cauda equina lesions, suggested by changes in bowel or bladder function, or changes in peritoneal sensations, dizziness related to vertebral artery insufficiencies, and any central nervous system disorder, such as spina bifida or multiple sclerosis, are also contraindicated. Worsening neurological signs are another important contraindication. Certain nerves are susceptible to injury because of their location or pathway. There are 5 susceptible sites. 1. In soft tissue or bony tunnels. A good example of this is the median nerve as it passes through the carpal tunnel at the wrist. 2. Abrupt neural branches, particularly in areas where the nerve's ability to move within the surrounding structures is limited. For example, the common plantar digital nerve in the web space between the 3rd and 4th toes has limited movement. It's formed from an abrupt junction of the lateral and medial plantar nerves, and it is a common site for Morton's neuroma. Number 3, in areas where nerves are relatively fixed. The common peroneal nerve, as it traverses around the fibular head, is an example of a relatively fixed nerve with little mobility. Number 4, high friction areas where nerves are close to unyielding surfaces. 2 examples are the nerves passing through the plantar fascia in the foot and the brachial plexus passing over the first rib. Number 5, tension points, such as the tibial nerve in the popliteal fossa, where abnormal stress can be placed upon the nerve. Treatment can be direct or indirect. Direct treatment is the same as those used to examine neural tissue. Indirect treatment can be as simple as changing posture and often involves altering a soft tissue structure, which affects the nerve. For example, a hamstring stretch can affect the sciatic nerve, and a cervical stretch can affect the brachial plexus. Neuromobilization is not a common treatment and should only be used in a last resort and under physician protocol. There are 7 basic neural tension tests, 1 for the spine, 3 for the lower extremity, and 3 for the upper extremity. The spine test is a passive neck flexion. The lower extremity tests include straight leg raise, slump test, and prone knee bend. The upper limb tension tests are the ULTT1, 2A, 2B, and 3. Passive neck flexion is performed with the patient either sitting or lying supine. In the supine position, the patient does not use a pillow. The patient initiates the neck flexion and lifts the head off the table. The clinician places their hand under the head to support it and moves the neck into flexion while the patient remains relaxed. A straight leg raise, also known as Lassoverix Test or Lassoverix Test. The patient lies supine and the clinician places one hand on the foot and the other on the quadriceps just proximal to the patella. The extremity is lifted by the hand on the foot, while the hand on the quadriceps keeps the knee from flexing. If enough flexibility is present, the patient's leg may be placed on the clinician's shoulder. Neural tension may be increased in the straight leg raise with the addition of passive ankle dorsiflexion, ankle plantar flexion with inversion, hip adduction, hip medial rotation, or passive neck flexion, individually or in combinational movements. The prone knee bend, similar to a quadriceps stretch. With the patient prone and the head turned to the side being treated, the clinician grasps the leg above the ankle and flexes the knee, moving the heel toward the buttock while maintaining slight hip extension. The prone knee bend is used to examine or treat anterior thigh and groin pain. The slump test. The patient is sitting on the table in a slumped or sagging position, and the hands are behind the low back. We apply pressure to the shoulders to bow the spine without changing the hip position. The patient then brings their chin down to their chest, and the clinician applies slight overpressure to the head. The patient then extends one knee and follows this motion with ankle dorsiflexion while keeping the knee extended. Neck flexion pressure is released slowly. If the patient reports symptoms before the entire technique is applied, it is not necessary to go through the full procedure. This procedure is not recommended for any patients with suspected disc injury. The upper limb tension test 1 for the median nerve, also known as the brachial plexus tension test or Elvie's test, is used to test the median nerve and to treat symptoms of the thoracic spine, neck, and arm. The patient should have full range of motion of the entire upper extremity and neck and no irritable disorder. The patient lies supine. Place the hand on top of the shoulder and apply a stabilizing force on the shoulder girdle to prevent elevation throughout the treatment. Abduct the patient's arm to 110 degrees while staying connected with your thigh. Laterally rotate the patient's shoulder, then supinate the forearm and extend the wrist, thumb, fingers, and the elbow. The patient actively flexes the neck laterally away from the side being treated. Upper limb tension test 2A for the median nerve. Shoulder depression has a significant impact on the brachial plexus. This may be a better position than the upper limb tension test 1. The patient lies on a slight diagonal on the table with the head towards the clinician and the scapula off the table. The clinician stands at the top of the patient's shoulder with your thigh against the patient's shoulder. Hold the patient's elbow and the wrist. The clinician's thigh depresses the patient's shoulder girdle. Bring the patient's arm to about 10 degrees of shoulder abduction. Extend the elbow and laterally rotate the arm. Slide your hand down to the patient's hand and extend the patient's wrist, fingers, and thumb. Upper limb tension test 2B for the radial nerve. This test treats the cervical, thoracic, and upper extremity disorders, particularly those involving the radial nerve. The position starts the same as the upper limb tension test 2A. The clinician medially rotates the patient's shoulder, pronates the forearm, and then moves their hand to the patient's hand while they flex and ulnarly deviate the patient's wrist and flex the patient's fingers and thumb. Upper limb tension test 3 for the ulnar nerve. The patient is supine and the clinician stands next to the patient's side. Depress the patient's shoulder girdle with the patient's arm resting on the clinician's thigh. Laterally rotate the patient's shoulder, then abduct the shoulder. Flex the elbow, extend the wrist, and extend the fourth and fifth fingers. The patient can actively flex the neck laterally away from the arm being treated. There are other techniques for self-mobilization that patients can do at home. These include A, the sciatic nerve stretch, B, the brachial plexus stretch for the median nerve, C, a combined straight leg raise and prone knee bend stretch, D, the ulnar nerve stretch, E, the femoral nerve stretch, F, the radial nerve stretch, and finally, G, the slump test with the feet positioned neutral against the wall. These tests should only be performed by patients once they fully understand the effects of neuromobilization. Our patients need to understand the potential consequences of doing these mobilizations wrong.